Thanks for having me. And it's nice to see some familiar faces and a lot of new faces. And then I don't know if anyone was introduced to Carmen Murillo. She's our new nurse practitioner at our Scleroderma clinic, or in the rheumatology clinic. So you want to wave hi? Some of you may be seeing her face too. So I'm going to be talking about calcinosis. This is a personal interest, because I think it just affects so many people with scleroderma, and it's a really understudied area that has a major impact on people's lives. Okay, so just disclosures, I'm a consultant for Cabaletta Pharmaceuticals, which is a company that's developing various cell-based therapies for scleroderma and other things. Okay. We're going to be talking about what is calcinosis in general, and then we're going to be talking about the science of calcinosis, kind of diving down into the nitty-gritty. And then we'll talk about treatments with the caveat that there's a really lack of data in how best to treat calcinosis. So a lot of the things we use are based on case series, observational studies. We love randomized controlled trials, but they just don't exist for calcinosis. And the key questions we're going to answer: what is scleroderma-related calcinosis? What do we know about what causes it? And then what do we know about how to treat it? Okay, so calcinosis overview. So there's a big misconception that calcinosis is because you ate too much calcium or there's too much calcium in the blood. It is not. So calcium in the bloodstream, those levels are normal in people with calcinosis. It doesn't have to do with your dietary calcium. Actually, some people can be calcium deficient and have osteoporosis and have calcinosis. Why would you have weakened bones and then be depositing calcium in different areas of the body? This is a big question, right? So it's not exactly bone. It feels like bone, but if you look under the microscope, it looks different. It's not quite as organized. Bone almost looks like a little kind of meshwork of different canals, and it's very organized. Calcinosis is not that organized. So the vast majority of people who get calcinosis related to scleroderma will have the hands affected. And very inconveniently, the most common place to be affected is the thumb of the dominant hand. So the hand that you use the most, the finger that you use the most, is the most likely to have a little lump of calcium. And it is maddening, because that is the very worst place to have a lump of calcium, is on the thumb of your right hand, or if you're left-handed, on the thumb of your left hand. And so it often occurs, it can occur usually around joints, so it occurs at the tips of the fingers, but it can also feel like almost like the joint is becoming more lumpy. So this is a more rare complication. About 4% of people with scleroderma will get more calcinosis than just the fingers and will have what we call a heavy burden of calcinosis. And when it occurs, this is really devastating. It happens around the elbow, can make the elbow hard to bend. Sometimes that calcinosis lump gets so big that the skin starts to break down around it, or you bump it, and then there's an open wound, and it becomes very hard to heal. The other thing that can happen with calcinosis is they're big lumps, and guess what? You've got a lot of nerves in the elbow, and sometimes calcinosis can pinch a nerve, and then you've got, feeling like nerve pain on the arm. Another inconvenient spot. Calcinosis occurs in the most inconvenient spots. So the knees, and this is a more severe calcinosis, but again, you're bending the knee all the time, you've got these calcinosis lumps, the skin gets thin and becomes easy to break down. In some people, especially people with muscle inflammation, we can see the calcinosis deep inside the muscles and kind of wrapping around the muscles. And same thing, this is just very uncomfortable, and it's just very bothersome in a lot of ways. So why are these specific areas so affected? Nobody really knows, but I have a hypothesis, because I've looked at scans for years before people develop calcinosis, and there are people with calcinosis who complain of pain 10 years before at the elbow, and there's an MRI that just shows inflammation around the joints and in the tendons. And then 10 years later, there's calcinosis there. And so the question, my hypothesis is that these are areas where joints and tendons are inflamed. And I don't know if anyone else has had rotator cuff problems or calcifications on the rotator cuff. That's common in people without scleroderma. Tendons like to calcify. So sometimes people get things in the Achilles without scleroderma. So these are areas of the body, they're attached to the bone, and they're very prone to calcification. So in scleroderma, tendons we know are inflamed. Is that something that inflammation leads to calcinosis years down the line? We don't really know, but that is the best hypothesis we have so far. So who's affected by calcinosis? About up to 40% of patients with scleroderma. When I looked at this data in our Johns Hopkins cohort, it was about 30%, but it might be an underestimate because we don't always ask you, do you have calcinosis, right? So sometimes you go to the visit and, that may not be the highest item on the agenda for that visit, and so maybe if someone doesn't ask you, you're not going to say. So people who with longer disease duration and more scleroderma-related damage have more calcinosis. So the longer you've had this and more complications you've had, the more likely you are to have calcinosis. So there's certain things that do increase the risk, which we're going to get to this later, but that I think may be something you can modify. So myositis, muscle inflammation, very common in scleroderma, but again, not always something we think about or we look for. But when that occurs, it's something that we do see that it increases the risk for calcinosis, especially having a heavy burden of calcinosis. And then there's antibodies called PMSCL antibodies that we don't always systematically check for. A lot of times people check for centromere, SCL70, RNA polymerase 3. There is a panel that you can send out. It's called the Systemic Sclerosis 12 Antibodies Panel. And it has, and any doctor, no matter if your doctor's here or in the community, they can send this. And you can go to LabCorp or Quest, and they have this full panel of scleroderma antibodies, and you can find out if you have these. But those antibodies increase the risk of calcinosis. So this is a study that we did in the Johns Hopkins cohort. They have a huge database of scleroderma patients because Fred Wigley has been taking care of people with scleroderma since the 70s. And so it's a lovely, rich database. And so what we did is we used, computer-based algorithms to try to see if we could identify groups, distinct groups of people with scleroderma. Are people with scleroderma all alike? Are they all in one group? Or are there different types of scleroderma? So what we see is those bottom curves there in the blue, the yellow is not easy to see, and the green. Those are groups with lower risk of scleroderma-related complications across the board. So we were looking at heart, kidney, GI, myositis, arthritis, tendon friction rug, Raynaud's, the whole bit. And we looked and we said, hey, computer, can you tell us, are there groups of patients who are more like each other than they are like the whole group? And there were. So there were 4 groups. And this group in orange is the key group here. So this is the group of patients with severe complications across the board. Severe skin disease, severe internal organ complications across the board. And guess what? Their risk of calcinosis was way up. So these patients who had the worst scleroderma across the board, they had the most calcinosis. So again, what do we think causes, a general schematic of what do we think causes it? So we think that scleroderma-related inflammation plus low blood flow in the tissue and scarring. And guess what kind of cells like low blood flow areas? Bone cells. So bone cells are the ones that survive in low blood flow environments. And is that low blood flow environment causing those stem cells in your skin or in your tissue to behave more like bone cells? This is another kind of way of looking at it. So all these factors combining together, and then at the tissue level, you have different sort of proteins that we can't necessarily always measure in the bloodstream, but different, proteins, cytokines, chemokines, fatty proteins, stem cells, loss of calcification inhibitors, and that whole combination may lead to calcinosis. We all know why calcinosis matters. I think many of us do, right? Because it affects you. It affects us. There's no known effective medication to prevent or treat. It's really disabling and it's disfiguring. And this is one of my favorite things, and this is something, my best argument for getting grants and funding for this, because when I was a fellow, I presented this to someone, very well-respected scientist. And he thought I shouldn't study this. He told me, don't study it. Nobody cares about calcinosis. So wait a second, right? So the same kind of proteins, the same kind of compounds that are in scleroderma-related calcinosis are in the blood vessels of people with coronary artery disease and atherosclerosis and rotator cuff tendinopathy. Okay, so don't tell me we don't care about this, right? This may be something that understanding this in our disease may be the key to understanding what affects 50% of people in America, right? So, and I think sometimes we don't think about it that way. We don't think about, hardening of their arteries as an inflammatory disease that shares some similarities to this very rare disease. So even though scleroderma is very rare, some of the things that are happening in the bodies of people with scleroderma are important to understanding and it's not easy to get a biopsy of an artery, right? But guess what? We could potentially get tissue from people with calcinosis. And I've had a lot of patients with scleroderma say, take my tissue, right? Let's look. Let's try to find out what's going on. So I think there's a good argument that this is not just a scleroderma problem. Okay? And then calcinosis, a big complication we see is that it gets infected. These open up and then they chronically drain, and then bacteria gets in and it requires surgery. And those surgeries can be really big and they can take a while to heal and it can recur after surgery. Sometimes it occurs in unusual places. So even though hands are the most common, okay, so let's talk a little bit more about what we do know about calcinosis. So calcinosis doesn't quite look like bone, either when we look at it or when we look at it under the microscope. So this is a 3D CT of somebody with calcinosis. And here, those calcinosis deposits are what looks like candle wax dripping all around the hips. And you can see there's that normal thigh bone, and then all these calcinosis deposits. That doesn't look very organized, right? That doesn't look like a new bone that is formed. That looks like something that is just growing. And you can see some of these white spots lower down in the thighs. Those are in the muscles and in the soft tissue. So it's not organized like bone. But it does share some similarities. So when we look and we do some staining under the microscope, there are bone-associated proteins that are present in the deposits. And then the other thing, if you have osteoporosis, they'll tell you, you've got to do weight-bearing activity because bearing weight is good for the joint, good for the bones, and good for your osteoporosis. You got to walk, you got to load those bones to build the bone. Well, guess what? Calcinosis does the same thing. So if you repeatedly are, typing, pressing on a thumb, pressing on a finger, or you hold your pencil between two fingers, that spot is where you're most likely to get calcinosis. So even if it's not, quote unquote, trauma, something that was an injury, if it's just repeated pressure over and over again, that's an area where calcinosis tends to form. So this was done by Lauren Packman's group at Lurie. So they have a good group of children with dermatomyositis, and a lot of those children have calcinosis. And what they did is a lot of abbreviations here, but the important takeaway is when you have skin, your skin should be producing skin proteins like keratin, collagen, skin proteins. It shouldn't be producing bone proteins, but yet it does. So in people with calcinosis, their skin cells are behaving like bone cells. That doesn't mean they actually are bone cells. It's sometimes cells can change the kind of proteins they make under different conditions. And they saw that in the deposits, they were having these bone-associated proteins. Also, around the deposits, they were having bone-associated proteins. And in the blood vessels surrounding, they were having bone-associated proteins. So if we look at the crystal, the actual crystal itself, the calcium crystal, it's the same one as in bone. So hydroxyapatite is the primary component. So this is also, and this is an X-ray diffraction study, which is actually very hard to do. It's very hard to identify a mineral, and actually you need specialized equipment to do this. So most research centers don't, this is not something a lab can routinely do. But this crystal is the same one that's in bone. It's the same one that's in atherosclerosis. It's the same one that's in rotator cuff disease. So this is not just a calcium and phosphorus coming together and linking up together in a random way. This is a crystal that's actively made by cells that are behaving like bone cells. So what does it look like under the microscope? Sometimes if you do a biopsy, I've seen biopsies come back and the pathologist will say morphia, which is just collagen deposits with dystrophic calcification. And then some look disorganized, so some look like liquid. So actually this can look like a paste, or it can look like a little rock. Sometimes it looks like bone under the microscope. And then there are certain cells in there called macrophages, which macrophage is, if you remember from biology, is kind of what's literally is called like a big eater cell. And it's a cell that comes in and tries to take away damage to the cells, or tries to repair and tries to eat up anything that shouldn't be there. And so these cells are present, but they may be because there's calcium crystals there that the macrophages are coming in and trying to get rid of them. So this is just an image of the calcinosis under the microscope. So those cells in black are the macrophages. And then here that F is labeled for fibrosis, which is just scarring. Okay, and then you see the macrophages there, and all that black is a special kind of staining for calcium. How do we measure calcinosis? So the most common way that I didn't put up there is we look in clinic and say, where's your calcinosis? Okay, and we touch and we see it's here, 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 here. But that's probably the tip of the iceberg, right? So there's certain things that we can detect on exam, and there's a lot of things, calcinosis, that we can't even see on an exam, and sometimes people don't even feel. So x-rays, there have been x-ray studies looking at how do we identify calcinosis, but it's only a 2D image, it's flat, right? So we're not seeing the calcinosis on the back, and if there's calcinosis behind the hand, it can be hidden because the bone is blocking it. There's CT, that does provide a 3D view, but it doesn't tell us how active it is. So it's a static view of how much calcinosis do you have at this point in time. So one study that we did over at Hopkins was the sodium fluoride PET scan. And so that sodium fluoride PET scan is a scan that has been done to detect bony invasion of cancers, because it's a good marker of is bone being damaged or being turned over. And it basically combines a CT scan with a radio tracer. And the radio tracer goes in and it hones in on calcinosis deposits that are actively forming. So it binds to that calcium where the calcium is exposed. It may not bind to a lesion that is just static, that is done. But if a lesion is actively growing, that radio tracer is going to hone in on it. Okay, so could it give us a marker of how active the calcinosis is and whether it's going to progress? And so what we saw a couple of interesting things. So here in A, you see a CT scan, and in that white with that arrow, that is an area of calcinosis in front of the knee. This is a funny slice of the knee. It kind of goes like, straight through, like on a horizontal through the knee. So you see the kneecap there and then part of the joint. And then in front of the kneecap is that area of calcinosis. And then in the back of the knee, it looks normal on the CT scan. So if you look at the radio tracer, so that's in B and C, there's different views of the radio tracer. So what you see in B is that red arrowhead. That's where the radio tracer is honing in on something at the back of the knee that wasn't visible on a CAT scan. And then if you look at that other view, and this is more like, it's almost like a heat map, that C, where that radio tracer kind of forms like a, how much intensity is there. You see that area in yellow lighting up in the back too. So the question is, okay, we see the calcinosis deposit lighting up. That's the blue arrow. We see that radio tracer is attaching there. But there's also radio tracer attaching where we can't see it on a CT. Is that something that's going to turn into a calcinosis years down the line, months down the line? So here's a view of the pelvic area. So in people with myositis, the pelvic area is very commonly affected by calcinosis. And so if you see those blue arrows, you see those white markings are calcinosis around the pelvic area and the soft tissue. It looks pretty mild, right? I mean, that doesn't seem like a lot of calcinosis. But then if you look with the radio tracer, that's lighting up intensely. So this is an area, and I will tell you, these deposits were painful. This person was having a lot of pain. Sometimes calcinosis is not painful. Sometimes it hurts. It's sore. People get fevers. It feels like inflammation. And so that whole pelvic area was lighting up. And the other thing about this is, too, the bones were lighting up. So this is actually not normal bone activity. This is increased. So we mentioned that calcinosis is associated with osteoporosis. Is this somebody who's losing bone from their spine at the same time that they're depositing it in the pelvic area and the soft tissue? That, I think, is a big question that comes up when we see an image like this. Okay, and we can't always feel the calcinosis, But here, this is a view of the thighs. Are deposits this big going to turn into deposits that are even bigger over time because we see so much radiotracing? Okay, so the science has not advanced to where we would like it to be, but it is something that, there's elements where we don't want to wait. This is a really devastating complication. And so there's certain things that our center and many centers across the country are doing for calcinosis. And we would love to have more data on how well they work and good solid data, but I will give you a list. This is a long list with a lot of text. So the two things I highlighted and read are things that really everybody should be doing. So one is protection from mechanical injury. So you don't want to be repeatedly bumping anything, putting pressure on any areas that especially might be prone to calcinosis. And then you want to treat ongoing inflammatory activity, especially in the joints or muscles, which we often forget about in people with scleroderma. A lot of people with scleroderma are on mycophenolate, which is a great medication for skin. It is not the best for joints or for muscles. There are other options that can be considered if there's inflammatory joint or muscle activity. So surgical resection you can consider in select cases, especially if there's a small deposit, sodium thiosulfate, tofacitinib, Xeljanz, and I'm going to go over these other treatments in a little bit more detail. Anakinra, which is an injectable, non-steroidal anti-inflammatories like Celebrex, ibuprofen, minocycline, colchicine, low-dose prednisone. And again, if there's activity, if there's joint activity, if there's muscle activity that warrants some of these treatments, that is something that we considered. And there's no FDA-approved medications for calcinosis. So going back to the study that we did, you saw this group with a lot of scleroderma-related damage had the most calcinosis, and people with fewer scleroderma-related complications had less. So if we treated scleroderma better, and if we had better therapies and we were able to halt the progression of the disease, would we see that in 10 years, a lot fewer of our patients have calcinosis? My hunch is yes. Unfortunately, we're not there yet, but we have many exciting clinical trials coming down the pipeline. There's things that we're very excited about that may make an impact. We have new FDA-approved medications for scleroderma, so we have more options than we had before. We're still not where we need to be, but it is something. That is our target, right, is stopping scleroderma. And, I would expect that if you did stop scleroderma, that would be my guess, is that you wouldn't see as much calcinosis. And again, how do we treat scleroderma better? So we talked about myositis. Remember this. Don't forget about myositis. A lot of times I've seen people with scleroderma say, I can't swallow, I feel like I'm choking, the fluid is going up my nose when I'm trying to swallow, my muscles are getting weak, I can't stand up from a chair. Someone will say, it's your scleroderma, you're on mycophenolate, right? No, check a CK, check an aldolase, especially there's a lot of overlap, so muscle involvement is common in scleroderma, but there's also certain antibodies where there is a true dermatomyositis scleroderma overlap syndrome, and that is treated in a lot of ways differently. So if people have severe myositis and they're having difficulty, especially, it's very common for people with scleroderma to have difficulty swallowing because it feels like it gets stuck in the chest. That's usually the esophagus. If it feels like you can't get it down in the throat, you can't make a ball, you can't push it down with your tongue, that is more myositis. So I think about myositis in people who have difficulty swallowing from this part, not this part. Okay, and then IVIG is something that does have, there are studies showing it has benefits for scleroderma skin. It's very difficult to get insurance approve it for scleroderma, but it's FDA approved for dermatomyositis. So if we know that you have a dermatomyositis overlap, it can be helpful for both conditions. Rituximab is another thing that we will sometimes use that can treat both. And then arthritis. So this is, again, another really common thing I see where someone's getting my hands are stiff, I can't make a fist, and someone, it's your scleroderma, right? Just stay on your mycophenolate. Well, did you check a rheumatoid factor, check a CCP, making sure there's not a true rheumatoid arthritis overlap? Because sometimes it's actually joint swelling that is causing the stiffness in the hands. It's not necessarily always the skin. We think, I think scleroderma, some people get blinders. Physicians, they get blinders, they think skin, but don't forget about the joints and the muscles. And there are specific treatments for that we can use. So, sometimes we'll use tocilizumab, Actemra, which treats scleroderma lung disease, but it's also a great arthritis medication. And then because we think that these cells might behave like bone cells in a low oxygen condition or low blood flow condition, we do try to maximize the Raynaud's medications and make sure that you're getting good enough blood flow. Okay, protection from mechanical injury. This was a frightening image I saw from Walmart. These finger covers, which I love the finger covers, the finger cots, but here someone has like a razor blade on their fingers. It just made me think that maybe this is very effective. But yeah, so I don't think they actually do this. I don't think you can do this. So don't do this at home, but at the same time, these are great. So often the cotton blend finger cots are really nice because they're breathable and they're easy to put on and they're very, they have some elasticity, but they provide a little bit of protection. If you want more protection from, injury, then it's the silicone-based ones, but they're not breathable. And sometimes they're a little bit harder to slip on, especially if you have arthritis. So a lot of people also just use bandages during the day, so like a little Band-Aid over the area that has calcinosis, just because if you're sticking your hand into a drawer and you accidentally bump the top of that drawer, sometimes it can open up that calcinosis and takes like a year to heal. Armrest cushions, if you're a work from home person or just in general a work person, it's good to have something often, again, to cushion your elbow. And then for the ones around the hips, you can do an egg crate, something else to give a little bit of extra cushion around the hips. So that should be everybody doing that. Now, if a deposit is infected, then a surgeon needs to be involved. It can also be, we do have surgeons in the area who will remove especially small deposits around the hands, and that can be really helpful. I would say a lot of these deposits look very tempting to remove, but they're attached to bigger structures. Remember that's 3D CT of the pelvis? That's deep, right? Again, see the tip of the iceberg, but that's going to be attached to tendons and muscles. And it can cause a lot of damage if you try to remove it, especially if it's active and forming. Sometimes people get a chronic draining wound after that. So sodium thiosulfate actually has pretty decent data. A Mayo Clinic did a review, and they looked and saw about 75% of patients noticed some benefit. Again, these are not perfect studies, but that's been my personal experience too, that this can provide some relief in selected situations. So it prevents calcium crystals from clumping together. And it's compounded, so this Bayview Pharmacy actually exists, even though this is all fake, data on here. We often use Petranix Pharmacy or Mayo Clinic Pharmacy, and it's we send in the prescription. They have to compound it into a gel or a cream, and then you just put on a thin layer twice a day. It can burn a little bit, so that's the most common thing that I say that people might complain about. It makes the deposits generally, if it works, it makes them generally liquefy and pop out. I usually see that it tends to work within a couple weeks, although the Mayo Clinic thought that it may take up to 4 months to work. Okay, so, and if your physician is not a physician here, you can access this presentation later, and this is literally this 25% sodium thiosulfate compounded in zinc oxide or Vanacream is literally what you can tell your physician to order from Mayo Clinic Pharmacy. Okay. So tofacitinib Xeljanz, my personal experience is that for people with active growing calcinosis, this is one of the better options. And so the reason that we started using this was because Julie Pack, who's a myositis expert at Hopkins, did a clinical trial on Xeljanz for dermatomyositis, and lo and behold, they felt, wow, Xeljanz was pretty good for the skin in dermatomyositis, but whoa, was it good for calcinosis? Okay, observation. And that's been our experience too, that for people with really severe, this is something I would reserve for people with really severe calcinosis, and if they have arthritis too. Xeljanz is an arthritis medication, so if you need something for arthritis, this is a good option if there's also calcinosis. So we typically give 5 milligrams twice daily, but higher doses can be used. We've used up to 10 milligrams twice daily, which is more like inflammatory bowel disease dosing. Infection risk is really high. Even though this is a pill, it has a higher infection risk than some injectable medications, so that's something to consider. And we always recommend that people get vaccinated for shingles before starting this medication because the shingles risk is very high. And for people under 50, the shingles vaccine is not, people under 50 are technically not indicated to get the shingles vaccine, which can make it really difficult to get insurance to cover it. And so you have to monitor liver enzymes, the cholesterol, white blood cell count. It's not a benign medication, and it's not for everybody, but it is something we think about when the calcinosis is really severe. A lot of people with calcinosis have tried minocycline. in my perception and the perception across, the country, we have a calcinosis working group with the Scleroderma Clinical Trials Consortium is generally a little bit underwhelmed by minocycline, but some people do find it's beneficial. It's an arthritis medication too. So, years ago, this was a commonly prescribed medication for arthritis. Typically, people dose it 50 milligrams once or twice a day. And again, it can be helpful for arthritis. One thing you need to know is that it can cause permanent bluish discoloration of the nails and the skin. And sometimes the calcinosis too. So the calcinosis, if it comes out, it may be bluish gray. And that is something that's not reversible. So just keep in mind, the drug-induced autoimmune disease is a less common side effect, but that is out there too. So colchicine is an anti-inflammatory, and it's commonly used for gout and pseudogout, which are also crystal-based diseases. And so it does seem to help for people with those inflammatory symptoms. It's painful, it's warm, it's red. It blocks neutrophils from migrating into the area of the crystal formation to cause inflammation. Typically, we dose it 0.6 to 1.2 daily. It can cause some loose stools or diarrhea, so that can be a consideration with that. And it's not appropriate for people with renal failure. Anakinra, this is something that the NIH sometimes prescribes when someone has really severe calcinosis. Again, it's also a gout and pseudogout medication, and it's a daily injection, typically 100 milligrams daily. It causes a lot of injection site reactions, and so this is, again, not the most fun medication. The injection site reactions are pretty wicked. And it's very expensive. It's difficult to get insurance to cover. More appropriate for people with a lot of those fever or inflammatory manifestations due to the calcinosis. Doesn't necessarily seem to change how big the calcinosis is. So nonsteroidal anti-inflammatories like ibuprofen, Motrin, naproxen, Aleve, Celebrex, they're good options in select people. Even though these are over-the-counter, you do have to ask your doctor whether you're somebody who should be taking these, because a lot of people with scleroderma have GI issues, can have GI bleeding, have kidney issues, and you don't want to be taking this if you have kidney issues or if you have significant GI issues. For some people who don't have those issues, they can be good anti-inflammatories and help with pain. They don't reduce the size, as far as I've seen. And then so diclofenac gel or Voltaren gel, that's a nice option. That's an alternative. Usually the GI docs are okay with that, and people who can't take the oral ibuprofen or Motrin, and you can rub it on 4 times a day just to the area of the calcinosis, and that's available over the counter. Okay, so calcinosis and osteoporosis, we've mentioned this a couple times, and this comes up a lot. So people with calcinosis are at increased risk of low bone density, osteoporosis. If you have calcinosis, make sure, especially if you're over 50 or postmenopausal, make sure you ask for a bone density screening. People with scleroderma in general are at higher risk of low bone density and fracture. So this is an important thing to think about. Even if you're not going to be on a medication, it's important to think about your bone health, think about strengthening your muscles, fall prevention, calcium, vitamin D. And if you need a medication for osteoporosis, we generally try to avoid using something called teriparatide or Forteo, which is also known as an anabolic or bone builder medication. And there's this concern that if we're building bone in the skeleton, we might be worsening calcinosis in the soft tissue. You can use this in certain situations. Other medications are generally okay. There's variable side effects in people, with calcinosis and without. But it shouldn't prevent you from treating osteoporosis, because a broken hip is really, it's a life-threatening condition. And so, you have to kind of think about the risks and benefits of what you're doing, but don't let calcinosis stop you from thinking about osteoporosis or treating osteoporosis. And our program, I'm sure I left people out on this, but we have a really, lovely program of, lots of doctors, many of whom are here, who are interested in treating people with scleroderma, studying scleroderma. We have a lot of, research activity that's happening behind the scenes that many of you may be asked to participate in if you come here. And then there's clinical trials that are, so it's, I just wanted to say thank you to this whole program, because it really, you can't, take care of people with scleroderma without having all these people together, the scientists, the pulmonologists, the GI doctors, the cardiologists. So it really is a team effort. And I want to thank all of you who've participated in many of these efforts to try to advance, cure for scleroderma. And then, of course, a special thank you to Stephanie Gresh.